David Coates, Professor of Computer Science and Associate Dean of the Faculty, and I'm here to welcome you to this ISTS-sponsored event, ISTS being the Institute for Security, Technology, and Society. And this is one of half a dozen or so speakers we've had this year. And I'm very pleased to introduce Latanya Sweeney as our speaker for today. Latanya is a professor at Carnegie Mellon. In particular, she's the Distinguished Career Professor of Computer Science, Technology, and Policy in the School of Computer Science at Carnegie Mellon University. And she is the director of the Data Privacy Lab there, which has done all kinds of interesting work over the years. Perhaps one of her best-known results is about K-anonymity. And if you haven't read that paper, it's a really seminal and interesting paper. Many of the students have read here. She's won many awards from various organizations, including the American Psychiatric Association, the American Medical Informatics Association, and the Blue Cross Blue Shield Association. And these are not the kind of associations computer scientists normally get awards from, which is makes her all the more interesting. She was named a fellow of the American College of Medical Informatics in 2006. She got her PhD in computer science from that little-known Cambridge organization, MIT, I think it's known as, in 2001. And she got her undergrad degree from that other Cambridge university, that's Harvard, who is our arch rival here at Dartmouth. So I'm sorry, I have to play on that a bit. And she joined the faculty at CMU in 1998, and she's also the editor-in-chief of the Journal of Privacy Technology. It goes on and on. There's a lot of fascinating things to know about Latanya, and I'm very pleased to have her here today.
Thank you. I had the opportunity to have conversation with many of you. I had a great time all day. I think I've smiled almost all day. We had some conversations, some really active opinion conversations outside, so it's really nice to be here. Let me also figure out how to use my computer. Okay, there he goes. I want to thank David and Nicole for arranging this. I really appreciate it. It wasn't the easiest thing to do. At times I was like missing in action because actually I'm on my second year sabbatical, actually, at Harvard and MIT, so that's in Cambridge. I still live in Pittsburgh and have students at Carnegie Mellon that are trying to get their PhDs done. And I'm also going to DC, so tracking me across that was no easy task. So I really appreciate your perseverance and your help. So I did get this appointment to the Federal HIT Policy Committee, which is a part of the stimulus bill. I'm actually a congressional appointee, so in some sense I feel a little bit like a spy because I sort of give advice to the administration as part of this policy committee, and they choose to take it or not. But I am required to basically tell you that the things that I say are not their opinion, and I also have to say it's not even my opinion. So what I want to talk about today is sort of given the power of technology design and this whole stimulus bill thrust to build a nationwide health information network. Exactly what are the trust issues and how do we go about exploring those trust issues in this NHIN, this nationwide health information network? And what I mean by the power of technology design is pretty straightforward. Lawrence Lessig has a book, it's now in version 2 called Code V2, he really talks about how do I go about affecting change. He says, well, if you want to change society, you could do it by law, by market forces, by social norms, or by code for architecture. And I think we all sort of understand the first three. But a good example of code for architecture are things like things like how I set up a bus route. If I don't want inner city people to make it to the beach, there are many places where the bus routes make it almost impossible or extremely difficult for you to get to the beach. And so these are examples of what he meant by code for architecture. What I'm interested in is exactly this notion of this power of transforming the world, but that we want to do it through, and we already do it through, technology design. And so in some sense, what I mean when I say technology design, I think is really clear. It's the architectural code or the technology decisions that we make when we make new technology. This is extremely powerful. as computer scientists, we never really have appreciated the power of running the world that we really have. And, but we do need to come to grips with it, because sometimes we're creating problems in society that we could easily avoid if we just took the moment to complicate our lives or our problem statements with whatever the contextual issues might be. To give you a sense of how powerful I feel technology design is, let's look at it in contrast to the other three. In terms of law, do you know how many times a simple technology decision made by a designer in some Silicon Valley shop has just sent policymakers scurrying around to try to figure out what to do with this new technology? Even an example in my own work is some re-identification work I had done earlier, in which I was just basically taking online birth information and sort of using it to cross it in an interesting way with a cancer registry, and was able to re-identify these children. And the court was so appalled that they sealed the process. And I was really disappointed, because I was like, but this would make a great computer science paper. But the process got sealed. And what's really ironic about it is, if you were to see the paper today, it wouldn't even get published, because the truth is, it's not really that unusual or a difficult thing to do. But that's an example of how technology and technology design can interact with laws. And certainly, we've seen disrupt markets and make new ones. Perhaps a good example is the iPod. It's not necessarily a computer science whiz or anything like it. It wasn't even the first MP3 player on the scene. Its real innovation was the fact that it used the network to actually bring music and be able to purchase and load music so easily using the internet. But it has definitely changed the market. And social norms, well, social norms are things like, how women may have been treated in an earlier year versus now, or how blacks may have been treated at one time versus another. That's an example of social norms. But technology has also changed a lot of our expectations with respect to social norms. We can often think of mobile phones and emails, or even Facebook. It's hard to imagine going somewhere now without a cell phone, or not believing that a person has a cell phone. On my drive up here today, in fact, I was commenting on that we were like one of the first to have a mobile phone. And so when you went on the interstate and you saw a car pulled over, you would dial the local police and say, hey, there's a car pulled over, you should go check, and you'd keep track of sort of what exit you're on. Now you're like, nah, they got a mobile phone, they're under control. So it's a totally different sort of expectation. So there's a lot of power in technology design, and our realization of that came from the work that we've done in the Data Privacy Lab over the last 9 years. We basically were never funded by any of the traditional ways computer science is funded. We weren't funded through NSF grants or Department of Defense, mainly because they didn't know what it meant to be doing privacy and you were a computer scientist. So they said, oh, you must mean security, and we'd say no, and they said, well, we don't understand, or they'd say, you must be doing policy, and we'd say no, and they didn't understand. So instead, the way we were funded is a mechanism I call research by fire. So basically, some privacy incident happens on the front page of the New York Times. We got a phone call. Somebody had a problem to solve, either a new revenue stream they needed, or one they couldn't get, or they were being sued, or the court needed a court opinion. And so we worked over all kinds of privacy problems. It was an interesting ride, but it was in fact research by fire, in the sense that you had to come up with a solution, and or an analysis, and it had to be done in a limited amount of time. But we were really good at finding these sweet spots. In a world that wanted to talk about, you either have privacy or the utility of the new technology, we constantly kept finding these sweet spots of being able to give you both privacy and utility. And so last year, when I started my sabbatical, I was writing a book to summarize our experiences. And I realized that the trick that we were exploiting was really technology design. That a lot of times we were re-engineering technology or modifying the technology in a way that just found that sweet spot. And so the goal is to actually empower you, to let you know that you actually control it. You have a tremendous opportunity to choose the battles that will go forward in society and how they'll be shaped. So that's the big message to computer scientists, to upcoming computer scientists in general. So I took a little extra time to talk about technology design, primarily for the graduate students and undergraduate students that are in the room. Now back to the talk part. So what do we mean by the Nationwide Health Information Network, this NHIN thing? Well, it's pretty simple. The idea is that we want to share health data widely. That is, all the relevant medical information should flow seamlessly across computers, devices, organizations, and so forth. So if here I am in Hanover, if I were to become unconscious and have to go to the emergency room, I would think that if we had a nationwide health information network, they should be able to find my allergies and medications in the emergency room here, even though my doctor is in Pittsburgh and my most recent doctor I visited was in Boston. And so the idea, what motivates this is there is some anecdotal evidence that doing so will provide some significant improvements to patient care and will reduce costs. So that's what the vision is, but what's today's current setting really look like? So I know some of you are quite aware of the medical setting, some of you are not, so I'm just going to take a couple of slides to kind of level set on that so we can all go forward. So basically the way health data works today, there are two worlds. There's the claims data of how you get paid when you go to the doctor, and then there's the clinical data of what the doctor actually recorded about the visit. And these are not the same. They're not the same in the way they're stored. They're not the same in the way they're shared. Basically, in terms of claims, it's a very efficient nationwide network already existing to pay claims. Almost every physician is already wired to it, already provides some clinical information on each visit. Clinical information doesn't even necessarily include all the local information of all the providers in the same facility. And then one of the most important differences that claims, well, I think the nice way to say it has been optimized for income. That is, you may not be as sick as your medical claim says you are, but that medical claim gives the most income for the physician. So the clinical record tends to be more accurate because it tends to document the actual patient care. So that gives us two different worlds. And now the question is, basically when we say a nationwide health information network, we intend to primarily change the clinical world. That's the world we really want to connect. And we'll talk more about that in a second. So even though what we're going to talk about with the NHIN is how to connect and make a large network for the clinical data, it's important to understand first how the medical data operates, because the way that the medical data operates and the kind of ways it deals with data in terms of the data it leaves behind are likely to find a version of that if we don't think about it and make certain precautions on the clinical side. So this is an example of a single patient who goes to a doctor where information is going. So the patient shows up at the top. She shows up at the registration desk of the provider. So these sort of square shapes, rounded squares, are actual entities, and the circles are functions within those entities. So she gets registered, then she goes in for service, sees the doctor. The doctor might order some labs, may even give her a prescription to send to a pharmacy, may send some of the information out to be transcribed if he took notes, then sends it off to a coding system, which basically tries to maximize his income. He then can send his bill either to an insurance company or a clearinghouse. And if it's to a clearinghouse, the clearinghouse will then send it to the insurance company. It goes through some processes by which he actually might get paid. So this is a pretty laborious process. Let's kind of walk through it a little bit on two things. There are two particular cycles that are important. The first one is to verify. When the patient shows up at registration, they have to verify that you actually have insurance. And so they actually run a check, or they tend to run a check, and it could go directly to the insurance company for verification or to a clearinghouse. Let me say a little bit. I think the other ones are kind of obvious. There's a patient, a provider like a doctor, an insurance company, a lab, a pharmacy. But many of you may not say, who the heck is a clearinghouse? There's a couple of question marks over some heads I see. So what a clearinghouse is that basically this system is made as follows. The insurance company wants the provider to only use their insurance, only accept their insurance. So what they do is they modify the transaction codes that are required, or the way the transaction has to work, or the way they have to submit a claim, the process itself, so that once they're configured to work with one insurance company, it becomes hard to work with another. So if you're really large, like a large hospital, you can just hire people who know the different ways all the insurance companies work, and you have a group that does that. But if you're a small provider, it's really hard for you to do that. So that created a new industry called clearinghouses. And what a clearinghouse does is they basically they give the physician a generic claim, and the generic claim they'll follow the process or the special forms or anything that's needed to actually go submit it to the insurance company. The other circuit, well, we talked about insurance verification, and the other circuit is payment. So after it comes out of coding, again, it can do the same thing, either through a clearinghouse or through the insurance company for payment, and you may also have claims from the lab or the pharmacy. So those are the two circuits in the medical billing. You never thought paying a claim could be so complicated, right? The interesting thing about the process is not only how many parties are involved, but all of the places that there are independent data sets left behind. So this is an example. So clearinghouses, which many of you had never even heard about, actually have huge copies of data. Data coming from pharmacy claims, lab claims, as well as insurance claims, and so forth. Each group, a transcription company may not even be in the United States. A lot of them are offshore. So those companies also may have data about you elsewhere in the world. So it's kind of an interesting it's interesting to note how many different places and different players actually end up holding data. Now, why is that important? Because if I know who's holding the data, then we do have some regulations and some restrictions that apply on who they can give the data to. But there are very few limitations on who those people give the data to. So the more data sets I have, the more copies of the data I have, and the more unbounded secondary sharing I have, I think you get a good sense of how this creates a bit of a chaos in terms of the amount of data that's out there. This kind of data sharing is also hidden, so the patients have no control. They don't know about it. If it's incorrect, it's impossible to fix. PricewaterhouseCoopers provided a report in November where they estimate with the new emphasis to build an NHIN, this will become a $1 billion market. This is from a national, for the record, which is a National Academy report. You can't see it very well. This is from 1997. It's another way of saying, here's Alice has a particular, goes to the doctor, and this is an example of all the places in 1997 who would have copies of her information. I apologize for the poor quality. That was over 10 years ago, and without an NHIN. So when we think about where might be the data sharing today, let me give you an updated example. In 2002, when HIPAA was passed, HIPAA allows data to be shared freely if it can be certified as sufficiently de-identified. I had a technology that actually, you use it as a risk assessment server to identify predict how many people could be re-identified in a description of a data set. So 2 companies licensed that technology from us in 2002 and have been in the business of giving HIPAA certifications. In 2002, the typical request for a HIPAA certification was about 15 fields of data, diagnosis codes, procedure codes, and so forth, usually drawn over a particular region, like maybe Hanover or maybe an entire state, but usually if it was a small state, but usually a small region. And the number of patients involved were maybe 10,000, 30,000. Today, the typical request from PrivaCert or these companies for HIPAA certification is from a company you've never heard of, you have no idea how they got the data. It's for millions of Americans, and the number of data elements tend to be around 300. And it's longitudinal, whereas the others were single transactions. So it's a tremendous amount of data already flying around out there. Most of it is, of course, coming from the claim side. And with the NHIN, we expect to see something similar on the clinical side. So what's the stimulus thrust that I talk about to build this? So we have clinical data sharing. We have a lot of pressure there's always been a lot of pressure to force more clinical data sharing. That is, the insurance companies realize that the codes are that the claims have been upcoded or optimized for income, so they'd like to get their hands on more clinical data so that they could validate the amount of money being asked for. There are people who say, yeah, well, if we could reuse some of the test results, we wouldn't have to do as much testing. And there are people who would like to reconcile patient information. For years, maybe 12 years or more, these people have been putting pressure to do more clinical data sharing, and it got nowhere. What changed the world was the stimulus bill. Because in the stimulus bill, also known as ARA, it provided a model and gave money and policy attention to this area to actually make this a reality by 2015. So how does it work, this stimulus bill model? So it has some really interesting ideas. So the first idea is that it says, look, what we want to know, we want to make every provider a meaningful user of an electronic medical record system. So that's an interesting insight. That is, it's not sufficient that they buy an electronic medical record. They have to demonstrate to us or provide a means of demonstration that they're actually using it in a way that we determine is meaningful. The HIT Policy Committee was a big factor in trying to identify what would these meaningful uses be. There are about 122 of them. And this is an example of some of them. So ordering medications, labs, and so forth electronically, and being able to report the percentage that you ordered. Maintaining up-to-date problem lists, medication and allergy lists is another example. Making sure you actually do check your insurance eligibility, and it goes on and on from there. And as well as something like we just talked about in the example, if I was to become unconscious in Hanover, exchanging clinical information like medication lists, allergy lists, and being able to demonstrate that you have done that. And so if you do that, if you can demonstrate, you report you buy a machine if you don't have one, you provide these reports of 122 of these things, and then we'll reimburse you. We'll reimburse you up to $17,000 for a single provider and up to $40,000 for a hospital system. And then it ratchets up at 2013 and 2015 so that they're sort of staged out. But that's basically the model, how the money goes and how we end up with computers everywhere. So now let's suppose we're somewhat successful. We got computers everywhere. As a computer scientist, you say that's not a national network. That's just computers on a lot of providers' desk. And that's true. But it sounds really not surprising to any of us. But when I arrived on the policy committee, I was there 2 months, and I said, but how do the machines connect? Don't we need to talk about that? And there was nothing but blank stares. People didn't get it, that you had to actually describe it. What their thinking was at the time was that, well, we'll give money for regional centers, and regional centers will figure out how to connect to the people in their region, and the regional centers will figure out how to connect to each other. So this led to some interesting days. But in fairness to ONC, ONC is an obscure little office called the Office of the National Coordinator, who's no longer obscure in the medical community because they were empowered by the stimulus bill to be the overseer of this process. And they're led by Dr. David Blumenthal, and much to their credit, they actually did take criticisms that I provided, and others also joined in that criticism, and others also provided their own criticism. And they really stepped up to the plate. They hired technology people. They started working groups around the technology, and they sought out other expertise. So they have really been trying to close that gap, and we'll look a little bit later as to how well they've done. But the kinds of questions so in order to get their attention, I had to actually testify before the committee myself, because my attempts to sort of say, hey guys, didn't work. So I actually testified, and these are the kinds of questions I said you can't answer. You can't tell me when records for the same patient are actually belong to the same patient, and so forth and so on. I won't go through the list, but I think you get an example of the kinds of things that if you don't have connectivity, you can't do, but they're still related to your ability to achieve the meaningful uses. So we had a gap in readiness. Okay, so we talked about technology, the power of technology design. I think I've described to you sort of the vision of the NHIN, how the stimulus bill works to try to make that vision a reality by 2015. So now and I told you sort of where ONC started in their thinking, which was I don't think they were really thinking about it in any deep way, to a lot of effort they put. And this time we're moving at I call it stimulus speed. So a month is more like a year in terms of the number of decisions that have to get made and the actions that have to be taken. So let's look at the current state of what the NHIN design is from the ONC perspective. So the model that they have in the back of their mind is they say, well, you know, what's currently done is people fax. If I need to send, if I'm a provider and I need to send patient information to another provider, we contact each other by phone and we fax the information over. The approach ONC has taken is to let 1,000 weeds fester. And the reason I say it that way is because there are a lot of people who have a design. Many of them are driven by industry, and those industry partners have their own interests at heart. It's understandable. It doesn't mean that their design is necessarily bad just because it's from industry. But these are also competing designs. They're not consistent in any way. And ONC is sort of allowing this idea that let's let them all grow and somehow we'll have bliss because they'll all coexist together. These are quotes that when certain people who don't want to be identified in recent conversation, and when I asked them what did they think of the current NHIN construction, these were their quotes. And this was a really interesting one. He said, well, look, if this was a national highway system, you know, we have standards so that at least the cars are standardized. But the roads, you know, you might go down one road that's a one-way and meet another road that's another one-way, and there's no sign or anything to tell you. A red light in one area might mean the same as a green light in another. This is a total disaster in terms of trying to actually build a national network. Now, to give us some examples about what do we mean specifically, the two operant models is one's called NHIN Connect. NHIN Connect is the one that's currently operational primarily among federal government agencies like the VA, Social Security Administration, and so forth. And it runs off of a piece of software called NHIN Connect. The way NHIN Connect works, it pretty much has these 6 functions. So if I want to find out information about a patient named Alice, first I execute what's called the patient lookup. I give some demographics or explicit identifiers about Alice. I said, this is the patient I'm looking for. It'll give me back a patient identifier that's specific for that organization. Then I can do a document query. I can say, here's Alice's ID number at your place, and can you give me the documents for her? It'll then give me a list of document IDs that are associated with Alice. And if I want to retrieve a document, I give them Alice's ID number and a document number, and I get the document. It has some audit logs and other things. It also has this interesting thing called event messaging. What happens in event messaging is I can put a piece event on their system remotely that says, if somebody shows up with this criteria, send me information about them. And so it also has this idea of event messaging. In January, Microsoft and Cerner came up with the idea of using secure email. And the idea is, well, the closest thing to fax is basically if we had a way where providers knew each other, then they could just send email. They could just send this as attachments. And then all we have to do is build a kind of secure email system. So what's kind of wrong with these? So I'll just give you, the list is very, very long, but I'll just only give you a couple to give you a sense of how sort of letting the weeds grow won't get us to where we need to be. And in fact, because ultimately what we really have to do is we actually have to do technology design. We really need to design an NHIN properly. So the way event messaging works, I already actually told you, was that a third party is notified when certain criteria is matched. One of the problems with this is actually outside of the direct patient care. There's no requirement that this only be limited to maybe public health in certain jurisdictions may have a law that might require that, so this could accommodate public health, but there's nothing in the system that limits its use to public health. And this created some turmoil, I guess, on Fox News, saying that that basically anyone could do it. I wouldn't go as far as to say anyone could do it, but certainly it's not clear how broad the scope is of who could do it and what that criteria might be. Patient lookup, where I say, here's some demographics about a patient. Can you tell me whether or not you have patient information there? This one is a real problem because the model that they want to compare it to is faxing. But in some sense, there were some natural barriers when they were using faxes. That is, if I'm a malicious, let's say I'm a malicious stalker, and I'm trying to find Alice, if I know her medical information might be somewhere in a particular area, I'd have to call the providers by phone. I'd have to convince their office staff that I had a legitimate need to know the information that was in it in order to get them to fax it. So there's an automatic kind of vetting that's happening by that office, and there's also a kind of limiting factor in terms of how many people I could make those phone calls to. But with this patient lookup, I could actually just ping all of the providers across the nation or in a large area in just a matter of seconds to know where those records might be. I'll just give one more example, and that is that NHIN Connect supports, primarily is supporting the idea of is really a peer-to-peer sharing system if you think of it in security terms. And what that means is that these portals are sitting there in offices that don't really have any security people to actually make sure that they're up to date or even following the latest security practices. So this is a formula for a likely problem. The other problem, too, is there's a real debate that's been happening about whether or not if you buy a hospital information system that's certified as a hospital information system through the FDA, whether or not you can actually do security patches on it, unless the security patches themselves are authorized through the FDA, which means that if you were using a Windows kind of box, then there's a huge time delay that you'll be vulnerable before your patches will be authorized that you can use them. And then, of course, secure email. There are just a lot of things I just can't do with this model. A good example is the one that I've been using throughout, the Latanya's unconscious in Hanover, and I'm not sure how secure email is going to find my medications and allergies or who they would have to email. Okay, so I've sort of poked at ONC's current design settings, but now what I want to do is come back up a little bit and talk a little differently. I want to say, what are other kinds of trust issues? Because all of these issues were specific to design decisions that those places have made, the two weeds that we looked at. But now we want to say, in general, what do these trust issues look like? So let me give you a sample of some of these kinds of trust issues, and then we'll go on to talk about a sample of some kind of designs. So one kind of trust issue is called deduplication. That is, I want to know how many people are out there, how many patients have a particular disease. So the patients present to the providers, and maybe I have regional groups, and maybe the regional groups will help me figure out the answer. Now, in general, that wouldn't be too hard. You could just simply say, well, I'm just going to count the number of patients. The problem is deduplication. I don't want to count the same patient more than once, but some patients visited more than one provider. So the way this is traditionally done is they basically capture the Social Security numbers of the individuals, and then I just simply do distinct on the Social Security numbers so that I can deduplicate them. So the goal is to get a distinct global count, and the common approach of using Social Security number creates a privacy concern. And so one idea is that I need a design where I could do a kind of global calculation like that, or global deduplication, but they may not necessarily have this privacy concern. Another issue, another kind of trust issue, so these are just examples of some trust issues that are just generic, that any NHIN design would have to address. Another one is testing and liability. We've heard a lot about this. This particular example comes from our own work. We had done some work to re-identify DNA. So you give me a DNA sequence, I can tell you who the person is. And we chose the state of Illinois, we chose gene-based disease, Huntington disease, and we were excellent. We got 80% of them we were able to uniquely re-identify. Now, but in the process, we noticed an interesting thing about testing, That is, someone would have a particular disease in, say, rural Illinois, and they would go to their local provider, and the local provider would run a test local to the lab. The provider gets it back and says, yeah, you look pretty ill to me. Let's take you to the regional provider who might be a specialist in this area. They go to the regional provider. The regional provider doesn't trust the results from the local lab, so they run the results at the lab associated with the regional provider. It comes back, it says, yeah, you're really ill. You know what? All of these children ended up having to go to Chicago. So here's the health center in Chicago, and the health center in Chicago said, you know what, we've got to run that test again, and we did in the big lab. In fact, one of the ways we re-identified them was these kinds of patterns, sort of going backwards to what was the local community from which they came. But this also gets into a kind of interesting trust issue with respect to the NHIN. The issue being that all of these tests are repeated, and some people say, well, if we had a national network, we wouldn't have to repeat them. And the truth is that's not true, because it has to do with liability. That is, what makes this guy go here is not that he couldn't get the results from the other labs. He just doesn't have a trust relationship with the other labs. He knows that if this lab screws up, he's not going to give him any more business, and neither is his friends. And he's situated in a way that he needs to be responsive and responsible to these providers. And that's the same for each one of them. So there's actually, in this kind of model, and for many other reasons, a lot of good liability reasons as to why it's not likely that the number of that the amount of testing done will necessarily reduce.
So for some applications,
By the way, is this too loud? It's echoing in my ear. You guys are good? Okay.
for some applications, redundancy is actually good.
Yep.
How would you estimate the percent of good redundancy in replication of these tests?
It depends on the false positive rate of the test.
Right, but that takes domain knowledge in.
No, but that's okay. The providers have that domain knowledge. They know. So I'll give you an example. I rescued a cat. Who in the world would think I'd ever talk about that in a talk? So anyway, we rescued this cat. He was really ill. Take him to the doctor. Rushed him to the emergency room for the vet. And it turns out, among tons of things that had happened to this poor cat, he has feline leukemia. And he survived. He survived a car hit, eating rat poison. I mean, the list was, he had been out in the winter ice, snow for days, and he lived. And they said that this is crazy, because if he has feline leukemia, his immune system, he never should have been able to live through the night. So not only did he live, he got fat, he got healthy, he looks great. He doesn't show any signs of this. So we said, must be a false positive on the feline leukemia test. So we ran another one, came back the same way. We then ran another one that was more expensive but more accurate. Still came back the same way, so not so good for us and him ultimately. But I think that's a very common kind of way of how the reasoning goes around these testing. That is, I got a result, but the stick test that they used for him had a higher false positive rate than a blood test. So we did the blood test, and you could just keep doing these kinds of things. So I think that kind of interpretation is still, at the end of the day, going to be on the provider side, who's probably still looking at liability as a reason to. In fact, we had a conversation similar to that earlier.
So you would say that a non-replication of test results is something of a red herring. They will be replicated.
No, well, not all tests will be replicated, but also duplication of tests will not go away.
Understood. Thank you.
Yeah, I was just going to make that point too, which you and I had kind of discussed earlier. So it's not just liability, there's a financial incentive oftentimes between those providers to redo the test. But also, in addition to that, it can be not about concern about the test itself, but about the lab at the local level. So it's not just that they have a relationship with the big lab, it's that they don't really trust not only the test, but the technicians at the local lab, and so they will redo the test.
So that's another example of a kind of trust issue for the NHIN. And there are things that we could do about digital signatures and making sure they're qualified in terms of paper qualifications, but that doesn't mean that this will really go away, especially at the end of the day, there is a liability problem for the provider, because if something went wrong, if he ends up cutting off the wrong leg, and he says, but here's the lab result, and it's clearly your right leg, but it was really the left leg, and the test was wrong, or something like that. It's the provider who's on the hook for the liability almost all the time. So let me give you a third, I'm trying to give you a sense of the kinds of trust issues. They're not always narrowly about privacy, but they're huge in terms of the space of the trust issues. So this one is another example. This is a 24-year-old woman named Eve who goes to see an obstetrician who noted a murmur on a prenatal exam in her 21st week of pregnancy. She doesn't have any symptoms. She reports no history of allergies. And so the doctor recommends a prophylaxis and prescribes a particular one, and then the next thing you know, Eve is almost dead. And the problem was that Eve had a penicillin allergy, and the doctor didn't know. So suppose the NHIN had been working, and we could actually compile a chronological, so this, by the way, was a true story, and the part of it was that the young woman who had the penicillin allergy, when she had been given a particular, she'd gone somewhere and she got a particular prescription for penicillin many years earlier, and she did end up having to go to the emergency room, but there was a lot of confounders. She had gotten she had gotten drunk, and some other things had happened. And so when she went to the emergency room, she wasn't actually sure whether it was the penicillin or something else that was why she got ill. So she never realized she actually had an allergic reaction to penicillin. And so then she almost died. So when we look at this, if we were to look at this chronology, we see that she filled a prescription for penicillin. She went to an emergency room visit, where the emergency room visit definitely says that she has an allergic reaction to penicillin. So years later, when she would show up here, the doctor would say, hey, you have an allergic reaction to penicillin. But in reaction, suppose what Eve thought was actually right. Suppose that wasn't the case. Or suppose one of these was missing. That is to say that we have no way of knowing. When we put together a history of the care of the patient, we don't know whether it's actually a complete record, and we don't know whether any one record is actually right. That is, it may have been the case that she filled the prescription, but she never took it. And the description that's shown here in the emergency room is only because they thought it was a penicillin reaction, but in fact it may have been a reaction to something totally different. And so we can also find these kinds of errors both in omissions and actually show up in there, and there's no easy way to know what's what. So the goal is certainly to use the consolidated information over time in decision making, but it's hard to know which piece of data should actually be a part of that result, whether it should be valued or whether or not there's some data missing. Okay, so we've been trying to say that there's some really big space of trust issues that need to really be thought through in these NHIN design. I've given you sort of 3 applications with indirect issues. Let me just give you 2 more with direct issues, and then we'll look at some innovative NHIN designs and see what we think. So one of them is data segmentation. The idea of data segmentation is that a patient says, you know what, not every doctor I see needs to know the information from every doctor about me. It might be the case that if I'm taking an antidepressant drug, that my podiatrist may not need to know that. And so this concept of data segmentation comes up, where certain kinds of information can actually not be forwarded to other providers. And of course, for those of us in computer science, this is the inference problem. There are lots of dimensions to this problem. There is, of course, a liability problem that the doctor who's prescribing a new medication may not know that you were taking the medication that might have an adverse reaction. But there's also the inference problem. So you can imagine a patient who has a diagnosis of HIV, says HIV positive, says, I don't want anybody to know that, especially my foot doctor, or let's suppose whoever it is. But then the medications may still go, and AZT might be the medication, which of course highly correlates with HIV positive. And so this kind of inference problem, that is, you might choose a piece of data that you want to segment, and assuming there is no liability, or you, the patient, assume the risk of that action, you can't even be sure all the places that you've actually gotten all the places that could infer the very information you're trying to hide. And another problem is just correcting information. data that just gets into these records that are wrong, and for lots of really good reasons that happens. Often it's about a workflow interruption that happens. The provider's asked to go to another incident. They come back, and sometimes the records get crossed with the next person they see. There's a long list of recordings about how these things happen, and it could just be a typo. The problem is you don't get to see the record if you're the patient, and even if you could see the record, you might be able to correct it locally, but if it's already been a part of a big sharing network, how do you actually make sure the corrections get propagated? Okay. So about now so now I should really tell them the bad part, right? Okay, so here's the bad part. Normally, when a computer scientist gives a talk, they give you a really hard problem, and then they dazzle you with their brilliance of how they solved this problem. So I'm going to give you a really hard problem that's actually going to get harder, and then I'm going to leave you without solving it, but say that this is what we want to do. So let's look at some of the designs. And this is true. This is what we want to do. We are currently pressuring ONC really hard as we possibly can, because we feel like this is the last window of opportunity to get this right. Otherwise, it's just going to be a horrible mess. And what we're trying to get ONC to do is to fund us to formally model about 6 different competing NHIN design characteristics, and the 3 base case, the 2 that they're currently using and the faxing. And then you can almost think of it as a summary report where every row is a design and every column is going to be an important property or one of these trust issues. And then we could give ONC and the policy committee a spreadsheet that could say, you know what, for every design, we suspect there's going to be some problem with every design. But we can articulate the key problems with any design, and some will have more than others, and some will have problems that might be able to repair either in technology or policy or the merger of them. But at least you can choose your battles wisely, as opposed to the route you're on now, which is a route that's sort of building up. You get the sum of all the weeds. So you're going to get hit with privacy problems over here and privacy problems over there, and this one didn't have it, but that one does, and so you basically end up with the worst of all of it. So let me give you a sense of these 6 designs. So the first one is global query. We say an NHIN design adheres to global query if I can answer queries across the entire selection. So a good analogy is web searching. That is, I can go to a web browser, I can type in a search string, and it gives me back a list of URLs that actually match my criteria. So if this were an NHIN design, we could envision I go to the machine, I might type in Latanya Sweeney, it would give me back all of the links to places that had information about me. And so that's what you see here. Sort of the directory tells me where places are, sort of like domain name service, you could think of it. Indices are sort of indexes into the search patterns. So this is very much like a kind of Google-like design. But what's a little different is this permissions thing. That is, that actually only the links that you're allowed to see come through. So it has a way of interpreting which links are you, the viewer, the person who's logged in right now, which ones are you actually allowed to see. So if I said I wanted to, if I'm sitting there, Latanya Sweeney, and I type in Sylvia Barrett, it should probably come back with none because I have no right to see her records, for example. And of course, in order for a system like that to work, in this case, these services are centralized. You do have to run a piece of software at each of these, which right away should say, well, we've got to be concerned then about the security of those, because that's just like the NHIN Connect peer-to-peer sharing problem. So we may not necessarily want people who don't have the resources to take care of the security of this running one of these. They may have to partner with someone else. But we like this model. One of the other advantages about this kind of design is, from a public health standpoint, it has a lot of nice features. That is, the aggregate kind of query I might run might be numeric results, it might be regressions, it might be percentages, it might even be an extraction of data. So when H1N1 broke out, public health could actually use this and get an incredible model of reports of H1N1 around the country. Yes, sir?
full set of policies, or the individual sources get to define their own policies?
Yes.
Both.
Well, we don't know. That is a part of the design question. But that's right at the place where policy and so I can build for you a permission system, and if it's but the question is who gets to set those permissions. So some of those permissions are already set by federal law. Some are set by state law. That's the easy one. Some might be set by business practices. And then comes the question of, do individuals get the right to do it? And that's a different question. So we could build such a system, but this is where it would go overall in the design, and ultimately it would be policy deciding exactly how that would go. Yes, sir?
So one standard question that we ask when we have to do a permission system, is it default allow or default deny?
Mm-hmm.
And depending on that, there is also fine art of firewalking. I'm talking about firewall, which is seeing writing tools, seeing how far you can get in and around the policy. Do you anticipate the same kind of activity?
Well, let me show you the next slide, and then let's come back and answer your question. So the next design does two things. One, it's a totally different design, but it also shows a different model of how permissions are done. So I want to show you this model, and then we'll come back. So this model is sort of like secure email, except it's actually a full architecture, not just email. So we have, again, sort of the directory service, and again, we have a permissions layer. So the way it works is Alice is the patient, and Dr. Bob wants to send some information about Alice to Dr. Kathy. So Dr. Bob asks the permissions, can I send this information about Alice? And I'm trying to send it to Dr. Kathy. If the answer is yes, you can send it, and here's the address for Dr. Kathy. It goes over to Dr. Kathy, whose machine says, I just got some information about Alice from Dr. Bob. Am I allowed to see it? And if the answer is yes, then Dr. Kathy actually gets to see it. It also keeps a public log. Here, we could use the same kind of permission that we saw before, sort of one rectangle, which sort of how meant it was all contained there. But this model shows us a decentralized. This part is interchangeable between the two, the permissions part. So the decentralized permissions basically says patients may have places out in the world where their consents are stored. States may have, I may write up a permission language for these policies, and each state, maybe the Attorney General in each state, actually decides whether or not a particular request would be granted. Hospitals could decide it, the federal government could have one, HHS might host one, and then patients could also have one if it was so deemed appropriate. So this one does exactly the same as the earlier permission model, but is decentralized. A third model, which we call patient central, is a little bit like patient health records, except it's an EMR and not a patient health record. So many of you are probably aware of Google Health or Microsoft Health Vault. Those are the two most common personal health records. And many organizations also provide web access to a kind of a patient view of their medical record. We mean something slightly different than all of those. What we mean here is that it's like one big filing cabinet of everybody in the United States. So, you know, if you want information about Latanya Sweeney, or if you gathered information about Latanya Sweeney, you basically store it in Latanya Sweeney's patient central file cabinet. One of these P's would go there. And if you wanted to retrieve it, you could retrieve it from there. So the idea is there's a centralized source. It may not actually be centralized globally, but there's one location for every one. There just might be, I might be able to choose which source I want to put my information in or be my repository. And the permission models for the state and the federal government would still be outside, but now I have also a nice portal to, if we were allowing patient permissions, that the patient could actually provide permissions there. Yes?
Owner of some of these data, because it seems in saying patient, provider, and public entities, government, you're making some very strong assumptions about who owns the data. It's not really Alice who owns the data even, because she can't even always get hold of some pieces of data about herself. And are you having to make some assumptions about both the proprietary nature of some of the data and sort of like just answering the question. And I don't quite see how ownership of the information fits into the permission model that you're talking about.
Okay, so let me level set everyone, and different people are coming from different backgrounds. The question had to do with ownership of the data. And so I want to tell you a little bit about what it means to own medical data. But before I do that, I also want to say, well, why don't I say that now? Well, I just wanted to say that our goal in these designs is to be minimally invasive. That is, what we're asking ourselves at each point is, what's the least amount of effort the government has to do to make one of these architectures work? So if I have to go and redefine laws, that's not a good idea. If it's a matter of policies that I can make on the architecture, that's easy lifting, as long as they're consistent with the laws. So that's one of the reasons that states might like something like this, because state laws do vary quite a bit on medical data. But something like controlling the data, so I have to tell you what the current setting is, and no, it's not our intention to change it per se, though this particular model begs the question. So I was telling someone earlier this, I'll never forget when I was in the middle of the HIPAA debates, it was the best way to understand ownership of medical data in the United States. The testimonies went like this. The first group to testify, so this would have been the late 90s. So the first group to testify was a representative from the American Hospital Association, who argued that the patient, what we were calling the patient medical record, was really their business records. That they had tax obligations, they had fiscal responsibilities to maintain records for so many years. They had, they're trying to run a business, so they have business associates who need access to these records and so forth, and that this is really their business record. The next group that testified was a representative from the American Medical Association. He started by showing the back cover, the back story in the New England Journal of Medicine, because normally the back story is a case study of a patient. Usually includes some images, not of the person's face, but of whatever part of the body it affects. And he made a case that says, you know what, this thing you call the patient record is really the intellectual property of the physician. That, you know, the patient came in, they were showing symptoms and so forth. They just were a bunch of facts. And what the doctor did was use her skill and her knowledge to figure out what tests to do, how to interpret those tests, what medications to take and prescribe and so forth. And so that in reality, this is really the intellectual property, and that's why this physician has the right to publish it without patient consent or knowledge, especially if the patient's not explicitly identified. And then, of course, the third group that testified was a patient privacy advocacy group who argued about human dignity kinds of arguments and things like that. And an expectation, the American public generally does believe that they have some ownership to medical data. There's absolutely no legal right to such in the United States. So what HIPAA, Except in New Hampshire. That's right, because this is the free or die state. And we'll come back. You know, actually, I should always put New Hampshire here because it's just such a good example. So what HIPAA did was it decided not to talk about data ownership, but instead to just talk about rights and responsibilities, that this is data, if you're covered, this is what you can do with it, what you can't do it, and how you go about doing that. And so we don't really seek to change that other than just where a copy of the data is located. Now, high-tech did kind of change it. So one part of the stimulus bill is called the high-tech provision. And the high-tech provision actually gave individuals the right to demand a copy of their patient information from their provider. So before that, you didn't necessarily, unless you lived in New Hampshire, have a right to actually get a copy of your patient record. And so that provides a basis for something like a patient health record. But it wouldn't necessarily have been the basis for this, because the basis for this is just part of the national sharing, the NHIN. And we talked about the medical billing backbone. To what extent could we leverage it to be the repository? Everybody's already wired to it. The claims, though, is everything. Even though everyone's already wired, the transaction data set is very, very narrow. It doesn't have the space necessary to transmit clinical information. But there's some interesting models about how you could still do that if you wanted a cheap and easy and fast way to have a national network. This last one isn't a national network as much as it is a description of data that says I'm basically going to put with any data that goes around some metadata, sort of a dependency tracking model. Or these might be sticky policies. So the way this works is, so the nurse had a particular value and she signs it. The doctor has a particular value and he signs it. The programmer who wrote the function or the manufacturer who provided the company the function, they would sign their device. And then that computation, the result of that goes to another doctor who might sign it and so forth. And what this allows me to do is it gives me a mechanism by which if I have a piece of data, I can follow its flow as to how it got to me. That is, Dr. X knows how that data got to Dr. X and can prove that this is the path that it took. This was the software system it came from, or the glucometer that the measure came from, or the doctor that or nurse that entered the value. And so this kind of idea of hanging policies off of that, or this kind of accountability, we term heavy data. Another version, and these are things, of course, are not necessarily mutually exclusive. They can also be mixed and matched a bit. So pointer addressing is the last one we'll look at. And the idea here is that I'm going to keep all of the values stored in a particular location. It might be a patient central model. But the idea is instead of passing copies of it around, I'm just going to pass pointers to the data instead. And so when I want, and I might cache some locally for computational speed or something like that, but for the most part, whenever I need to go fetch the data, I'm going to go fetch the most recent copy. So this is a model that definitely helps us, for example, with the corrections idea. Okay, so beyond the three base case ones, we've sort of introduced very quickly here 6 other designs. And what we'd like to be able, and we introduced 5 kinds of issues. And you can almost match them across, where deduplication, global query seems like that would go really well with that. Data segmentation and heavy data, or in correcting with pointer addressing, and so forth. You can see that each of the designs somewhat have a particular issue that they definitely face. But what are their other properties, and how do they compare on the other dimensions is still work to be done, and the work that we would like to do. So I'm going to stop there, leaving you numb and unsatisfied. And really numb, and some of you sleep. But no, I'm just kidding. Nobody's sleeping. She's looking like, who? Yes.
So what are you actually doing, and what can the technical community do to help you in your efforts to force a considered contemplation of these different options for this network that needs to be built?
So what we're doing is we're pressuring we're pressuring ONC very strongly, sort of leveraging my access to them, and the we. I guess I should say who the we are. I didn't put a people slide up. So the we is a group of researchers at MIT, a group of researchers at Harvard, and then some cherry-picked researchers around the country to fill in gaps that wouldn't be in the other group. And then we have about 12 advisors who span lawyers and people who've had intimate experience in the NHIN development in this environment, and RIOs and things like that, and people in medical informatics. And then what we have are 18 industry partners. Different industry partners like different designs, and they would like to build those designs out. But what it means to be partnered with us means that they don't build it out until we can give them a specification around what are the surrounding issues, and then build it out so that we can have better models. So if we were to do this in a year from now, we should have, in a few months from now, we would have the spreadsheet, and in a year from now, we'd have maybe 6 more designs, and then maybe even try to fix some of the weeds that are out there too, because they'd be informed by it. I don't know that there's a lot that the technical community can do right now. I do know, though, that this is kind of thing, because of the kind of privacy weaknesses that were shown with the current designs, the privacy advocates are picking up the banner and making a lot of commotion about it. And so that might help a lot. It's hard to know. You can push people, and then you don't know whether they'll do the right thing or not. And I do believe that I do believe this is the right thing, and I do believe ONC will do the right thing. One thing that is a pressure point, though, is on Thursday is a congressional roundtable about this. And that's public, and I think that will also be a pressure point for them. I think she was next.
Well, it was kind of a related question. I mean, what if, just to build on what you just said, what if they come back and say, okay, yeah, you can test 3 of them? Right, I kind of wanted to know if there was sort of a leading set of things, or more interest on one of the 6 or some subset of the 6, or you're trying to promote all of them to actually evaluate?
So I don't get paid $1 more whether I do this work or I don't, whether I do one design or another design. We don't have any IP interest. None of the groups of the core researchers have any IP interest in any of these as well. So the core project that we're actually asking them to help to do is exactly the one that says, here are 6 designs, here are 3 more base designs. Who knows, when we do this, we might even come up with a couple of more. Here are some trust issues and some other properties that are important, and this is how they all scored. The other thing that we're asking them to fund are cross-cutting efforts. That is, there are researchers around the country who specialize in certain kinds of things. For example, one of them is a group at WPI who's spent the last couple of years studying what happens when you bring in an EMR. How does it affect workflow? So we would like them to also, that's a nice cross-cutting. No matter how you look at this, there's a problem about authentication and credentialing. And so that's kind of we've identified some people that we think would be really good at addressing that space. And so there's these vertical things too that we'd like them to fund. But if they were the smallest thing, I think, to fund, and the most important thing to fund, is probably the beginning work. They don't need to fund the industry build out. The industry people will do that themselves.
You were talking about the matrix in which you have all the 6 models and the different attributes in terms of trust issues. Now, the question is, who defines the weights of those trust issues, which is more important? And I think that there might be a lot of biases in each of those. For instance, the patient might have a bias to hide information, but that might not be aligned with my well-being because of drug interactions or whatever.
That's right.
So who decides what value each of these trust issues has, and how would you address that?
So our job in the cell is to identify a kind of intensity of the problem and a nature of the problem. The resolution of that problem, whether it be in policy, ignored totally, or in technology itself, would still reside with ONC and the policy committee and those people who are responsible for it. So we don't make any decisions. Our job is only to inform and educate. Well, he got a chance, so we'll go with you.
Go ahead.
I guess we're trying to ask the same question. Is there any consensus or how much work there is in identifying the threat models to those?
It was the same question.
We're very married.
What do you have a comprehensive list of things that you consider that might be a threat when some data getting compromised, some part of the system failing? What happens then?
Just to give you a little bit more perspective, we've been trying to bootstrap, start thinking about a model for data loss to dedicated adversary. Supposing that there is a dedicated adversary, there might be, there's probably money in illicit copies of people's health records. How should we model the data loss, and how much data loss should we expect the system to normally operate at? I mean, every system has a certain amount of failures, a certain amount of data loss, even, you know, the most tightly controlled military ones. With each one of those models, and maybe with other models, depending on what the threat models are, you know, how much data loss should we expect?
So which way do you mean data loss? Do you mean economic loss to the subjects, or do you mean breaches?
Breaches, data loss to the dedicated adversary.
So the Senate, so Congress is on board. They're with you, and they're already moving. So they passed. They saw that writing on the wall, and so they have passed health breach law, and they seem prepared to pass more. And we could help them figure out the best ones to deal with if we actually knew which NHIN we had, right?
So to us, this is not much of good news, unless there are clear threat models. Because what we've seen happening consistently is that legislation is affected by warped threat models that are not really there, threat models that overstress an insignificant threat and understress much more a significant one. So to us, this question really is about the threat modeling. Is there consensus? Is there, what do the vendors think? What do the system integrators who hope to build those systems think? Obviously, the internet, right, has been the result of least effort by consortia of vendors to define threat models, and well, it's a mess.
Right. So there are two ways to answer your question. So the first way is pre-design, and then the other one is post-design. So, and I'll do them in reverse. If I gave you an NHIN design, man, I can give you some serious threat models, because in some sense the design makes certain things, exposes certain things more than it exposes others, and it brings forward threat models that another design may not bring. Pre-design, the concept of threat models isn't its normal. We don't think of it in the normal way that we might think of it in a computer security setting. Instead, we think of it as the harms and risk and constraints around the players, and that what we're trying to do is maximize some kind of utility over the use of the data with respect to those risks and harms. So a formal model for us for an NHIN design has to be expressed. At the end, it's going to have a set of equations as well around parameters that have to do with the patient, risk and harms and expectations for the patient, risk harms, so like risk harms, and you can almost articulate them more as risk harms and liabilities from the leaking. We assume that that's going to happen, and we assume that it's happening in the spirit of the data sharing. Do you understand what I mean? So I'm giving data. Alice goes to the doctor and gives a piece of information. The data goes into some kind of NHIN thing. If it's in the direct care of the patient, during the direct care of the patient, the normal threat model is exactly the same as the security threat model. But because you're designing the system, the threat model is a little different. What we would say is a threat model is that Alice may not necessarily expect that a copy of her data is available to the Department of Defense or to public health or whatever the issue might be. And because we've now taken the norm and we've changed the norm and allowed more players to have access or allowed this to that, we've increased her risk. So the shortest way to say it is we normalize to the current setting to say how much more harm or risk am I providing. It doesn't, I can't give you a specific to say this is how the adversary looks, because we think about it in a different way.
Mm-hmm. So if I were, I'm a bit of a hacker, you might say. If I were operating an illicit information gathering operation, just like people gather and trade financial information now, I would be starting to break out some schemas for leaked patient information and some infrastructure for correlating it, even as we speak,
Right,
right?
right. But in this world, you don't even have to do that. You can just buy it.
Well, yes, if I were looking to provide the service and profit by it, if I were looking to be the
Well,
seller.
then what are you trying to do? I mean, you know, the data sharing that we talked about on the the claim side, none of this stops it. That's still there.
Mhm.
And this doesn't necessarily alter it. And all of the other ways that people, every one of these designs makes it easier for more people to get data, and people want to repackage it. So, and you can already buy tons of health data.
Very good question. So, do you think that right now the state of illicit sharing, whatever it is not going to change much with the ramp up? Do you expect it to really shift into the next order of magnitude?
I expect it to shift into the next order of magnitude. I believe PricewaterhouseCoopers got it right. That it's going to become $1 billion market.
So, do you expect?
Sorry, you've answered more than you're asking.
We can talk afterwards, though.
Thank you very much.
Thank you.